So for everyone who's connected, please keep the chat box only if you have any issue with the presentation or voice, and drop all your question in Q&A box. We'll give you some instructions soon once we start, but always keep Q&A for any question you have for the experts, and for chat box, always keep for any comments you need regarding to voice, presentation, connection, on any other issue. And also, I will drop some links for the upcoming webinar on the chat box as well. So we wait still more time. The number is getting more increasing. Again, good afternoon, everyone. We are waiting 2 minutes more before we're kicking off today's webinar to give more chance for everyone to be connected. Thank you. So I will have some soft introduction, tell the people get more, to not let people waiting more time. So hello again. My name is Bahir Al-Badri from Medtronic Medical Affairs team, and I will facilitate today's webinar. I hope you all are staying safe, and thanks for being with us in the third episode of Join Us for Abdominal Wall Repair Series Wave 2. Last 2 weeks, we had inguinal hernia guidelines in real life webinar, and then followed by hernia during COVID guideline for hernia surgery during COVID-19. And today we will have the third webinar on laparoscopic ventral hernia repair, new technique, and the benefit of minimal invasive approach. And this will be led by Professor Henry Hoffman from Switzerland. Hello again, sir. And we will announce for the fourth webinar also as well at the end of our session. So please keep your eyes on the chat box. I will drop the links here. So all webinar detail, again, I will be announced at the end of webinar. So as you can see here on the screen, I will put some housekeeping for this webinar. Please spend a few seconds to read all instruction, but I will simplify for you. This webinar will be recorded for Medtronic training purpose. And this recorder will contain audio and presentation, but it will exclude the chat function and participant list. The video and audio are disabled for all participants, so you have joined on listen and view mode only. If you have any question for the expert, please drop in Q&A box or Q&A chat panel at the down, the toolbar at down or up according to your laptop you are using. So please keep your question all in Q&A. And please, whenever the question has come to your mind, please directly write in the box, because our expert, we dedicated 30 minutes at the end of our webinar to answer and address all your questions at last 30 minutes. You can send the message by clicking chat, as I mentioned. Please don't share any third-party personal data, including patient data, in your question or comments. This is for data privacy issue. And recording or taking screenshot or photo and image is not allowed. And at the end of our webinar, we will launch a survey. So please don't close the window at the end of our webinar, and take a few minutes to complete the survey to enable us to enhance for upcoming webinars. And I will start by definitely know that we are in Medtronic committed to continue support healthcare professional, and we can find that this webinar be useful during this time. So let's start me to introduce our expert, Professor Henry Hoffman. He's a consultant surgeon in private practice in Switzerland, Basel, and he is main clinical interest in minimal invasive hernia surgery, and he is a reviewer in several international surgical journals and member of many national and international surgical societies. And of course, Dr. Henry will give us more detail about that. So again, welcome. We'll have 60 minutes by our Professor Henry Hoffman. He will go through this webinar today, and last 30 minutes we'll keep for question and answer. And also Dr. Henry, he prepared a list of 2 questions at the beginning to keep you engaged, and also to have more visibility about the audience at the beginning. So now it's, I think this is a soft introduction from my side, and the stage of yours Professor Henry, please kick off the webinar today. Thank you.
Okay, hello everyone. I hope everyone can hear me. I think we may start with the two questions I prepared for this session before I start my talk. So this is the first one coming up. When do you operate your patient with the ventral hernia, and how often do you use laparoscopic IPOM technique? And I would like to all of you to answer the question now, that I just have an idea of what is the need of the topic I'm talking about and who is basically doing it laparoscopically. So go ahead, please. Okay. So the majority is like less than 20%, but at least 40% do it. 21% do it, 20 to 40%. Interesting. Okay. Can we have the next question then? Okay, when you do a laparoscopic IPOM repair, this is a question then addressed to the people who use this technique. Do you routinely close the hernia defect, yes or no? Or more in detail, always, almost always, sometimes, rarely, or never? So please go ahead. Okay, good. Okay, interesting. So sometimes and almost always, those are the main answers. I think 50% or almost 60%. Good. So then I think what I will do, I will start my my presentation. I hope everyone can see this. Hang on, give me just a second. Okay, I will start with that one. And hope I can start my presentation now. There we go. Okay, so my talk will basically be about laparoscopic ventral hernia repair. As Bahar have introduced me, I'm focusing mainly on hernia surgery, but especially minimal invasive hernia surgery. And you may have heard about new techniques which are in the market now, and I would highlight also the benefits of that approach. But before I start that, some of you may ask where the heck is Switzerland and where I'm basically located. Switzerland is in the center of Europe. It's between Germany, France, Italy, and Austria. And Basel, where my practice is and my clinic, is just straight at the triangle border between Switzerland, Germany, and France. I can literally see the other two countries when I'm looking out of my window. So this is where I'm calling from. And Switzerland is not only known for its fantastic landscape and nature and the mountains and the Alps and the lakes, also some good watches they built here, some good cheese quality, but most importantly, good hernia surgery. So my history is I learned my hernia surgery skills mainly at the university hospital here in Basel. It's a high force center for basically everything in surgery you can do. So they do acute care, intensive care unit, etc. So this is where I basically learned my skills till 2018. But since 2018, I'm together with one of my best colleagues, Philip Kirchhoff. We both worked at the university hospital, and we both found that it makes sense to focus on hernia surgery and do it in private business and do it highly specialized. And this is what we do for 2 years now, but we do a little bit more. Some of you may heard about this, the Swiss Hernia Days. This is a conference we have established almost 4 years ago now, and it's taking place every year here in Basel, Switzerland, and it's increasingly successful. Unfortunately, as you can imagine, this year we had to cancel or postpone it to next year because of the corona pandemic, which hopefully has not affected your daily life too much. There's some connection for Medtronic as a long time. I'm also very frequently at the IRCAD Institute and Strasbourg in France. This is not very far from here, where we have these excellent Medtronic workshops, which I really, really like to perform because the level of expertise which we find there is quite high, and And what the students or the surgeons can learn is like a very steep learning curve, excellent cadaver workshops there. So this is where my connection comes from Medtronic. But let's now focus on the topic. So whenever we talk about hernia surgery, I always care about what I call as the Bermuda Triangle of hernia surgery, or more in detail about ventral hernia surgery. And this consists of basically 3 pillars, or 3 edges of the triangle, which is complications, of course, pain and recurrence. And this is basically the 3 things we have to care for, and we have to try to avoid as good as possible, or prevent whenever it's possible. And you may all come across the idea of having a clue that complications became a business model in several countries already. It's terrible, especially in the United States, but even as you can see here, BBC News in the UK, that pain, especially after hernia surgery, especially related with meshes, is rocketing into the media, and it's you know, let's say like yellow press style headlines, and this made our work quite complicated and difficult. And we also have to be a little bit honest before we start this presentation here. How good are we? So in terms of, for example, using a mesh or not a mesh, this is the most important study which has been published in 2000 by Luyendyk, where they just compared in an RCT mesh versus non-mesh repair in a ventral hernia. Then you see, of course, the mesh repair is better, but when you follow up these patients 10 years after surgery, we still have a 32% of recurrence with mesh. This is unacceptable high. So we are not so good as we may think we are. So this is the starting point where I would like to initiate my talk, and also like, we are tending to downplay some problems, for example, pains. I mean, there's so many data about it, but still I think it's not in the forehead of most surgeons. Pain is a very serious problem. Also after laparoscopic IPOM, especially in the early phase after surgery, we have to look after that. And in terms of pain, this is really, I think, underestimated. This is data from a HerniaMed registry, which will be published soon, where they compared basically midline lateral defects, or when you do open repairs. And you can see when you have lateral defects and combine that with the component separation techniques, you almost have 1/3 of pain, 1/4 of the patient will still have pain 1 year after surgery. So that is really not good. So we are not that perfect. So how about the decision tree of this whole thing when it comes to ventral hernia? We basically have to decide, do we do it open or do we do it minimal invasively? If we do it open, you can see here, you can choose whether you use a mesh or you don't use a mesh. And if you use a mesh, that's a question, where do you put the mesh, and is the component separation necessary? If we go for minimal invasive repair, which is usually the IPOM technique, then we have to ask ourselves, do we do a bridging or do we do a defect closure? I just learned that the majority of you will close the defect. And then there's always a question, how much overlap do you basically have to have? And what about these new fancy extraperitoneal techniques we learned about? Just have a problem now with, hang on a second, yeah. The decision is very difficult, and I just came up with a few abbreviations from hernia repair techniques, which are the new extraperitoneal techniques. And they, even for hernia experts, it's very difficult to understand where exactly is the difference. What is TAP, what is TAP, what is MELOS, what is EMELOS, Tesla, ELA. So, and I have the feeling that every year 3 or 4 more new techniques are coming across the market, and that's increasing the confusion even among the experts. And I would like to highlight a little bit the more important things. The problem of ventral hernia surgery is that we all are experts, or some of us are really experts. And if you say, okay, how should I do it? How should I approach a certain type of procedure? And if you ask the experts, then you will get very, very different answers. You can see that there are some two publications where they basically provided 10 standardized ventral hernia cases, and they asked like 20 experts, and the answers they received, how to treat the hernia, which type of imaging modalities you need before, that was all totally different. So you do not have a real consensus among the experts. And this is quite surprising because when you think about that, there may be some guidelines. So when we go back to this decision tree, guidelines may help. And for open hernia repair until this year, although this is the most frequent ventral hernia repair performed, there was no guideline regarding open ventral hernia repair. We have it now from the European Hernia Society, but as you can see here, it only addresses umbilical and epigastric hernias. And this is, of course, leaving out incisional hernias or hernias in other locations. And that's a little bit a pity. It looks, when you go into detail, then you even see that the quality of the studies they could include into the guidelines is of low quality and low quality evidence. And that means that the level of recommendation is quite low. And this is really surprising because I wouldn't expect that from surgeries which are done very, very frequently, that you do not find any guidelines. The thing looks a little bit different when we look into minimal invasive repair. Then we do have updated guidelines from the International Hernia Society. You have from the SAGES. And again, a little bit of shame from the European Hernia Society, no guidelines available for ventral laparoscopic repairs or for minimal invasive repairs. And the next downside is a little bit when we consider the guidelines are only for the minority of the procedures. This is data from the HerniaMed registry, which is a large hernia registry, the biggest in the world, originating from Germany, but now including patients from basically everywhere, mainly Austria, Switzerland, UK, and Spain. And they collected like almost 32,000 patients with ventral hernias, and you see the majority of umbilical hernias, epigastric, and incisional hernias is done in an open fashion. And when you think back for laparoscopic repairs, we do have guidelines, but this is only addressing for the minority of the patients or techniques which are basically used. And of course, we have now the European Hernia Society guidelines for umbilical and epigastric hernia repair, for God's sake, but again, this is leaving out the incisional hernias. So in terms of guidelines, we cannot expect too much help, unfortunately. Okay, so this is now for the key points of my presentation. That was just the beginning now. So I would like to highlight the complexity and the risk factors we have to consider when we try to choose a certain hernia technique. Site of the mesh placement is a very, very important question. Should we do it open or minimal invasively? And if we do it laparoscopically, should we close the defect or should we bridge? And if we use laparoscopic IPOM, how much overlap is necessary? And I would like to spend a little bit of my time in terms of like highlighting these new extraperitoneal techniques. In terms of like when we start with a patient and when we see them the first time in our practice or in our clinic, and no hernia is like the other. So as you can see here, the guy on the left-hand side, he has a small umbilical or supraumbilical hernia. And you see the guy on the right-hand side, he has a complex hernia from the first beginning on, and that he certainly needs another type of approach. And whenever you read a referral letter or an operation report where it's mentioned, oh, this was a complex hernia, most surgeons are not aware of what a complex hernia is. But since 2014, so 6 years now, Slater and his colleagues have published a review-based recommendation to define the complexity of a hernia. And I don't want to go too much into the detail, but the complexity of a hernia is defined by its size and localization, which means the bigger the hernia is, the more complex it is. And the more lateral the hernia is, like flank hernias, they are more complex than hernias at the very ventral part around the umbilicus. Second point, of course, is contamination and soft tissue condition. If you have a dirty wound, a dirty hernia, like from perforation, that's another piece of cake. That's going to be complicated and complex. And even if your soft tissue condition, like the guy in the video where we have some skin mesh repair of an laparostoma. That's complexity. And don't forget the patient history and his risk factors. If you have a smoker, if you have an obese patient, or a patient with diabetes, or a chronic heart failure, or when the patient underwent several abdominal wall reconstructions or abdominal operations, that is a complexity. So every recurrence, for example, is a complex hernia by definition. And of course, the clinical scenario. So when you have an emergency case or like a nice elective plan case, that's something different. So be aware of that. And you all know this graduation of the risk factors or the wound risk factors of the hernia. You have grade 1 to grade 4, and that's all correlated with your risk of surgical site infections, which is a complication we try to avoid. So whenever you have risk factors, is grade 2. Whenever you have potentially contaminated wound, like a stoma is on the side, then you have stage 3. And grade 4 is whenever you have an infected mesh or an septic dehiscence or something else, when you have a really contaminated situation. Side of the mesh placement, there has been quite recently a publication where they have agreed to define the mesh positions, because this is also something which gets always confused. This is a publication from Philip Meissems and his working group from Belgium, which are defined like onlay, inlay, retromuscular or retrorectus position, preperitoneal, intraperitoneal position. This is something you always have to keep in mind. And please, if you do an operation report, please really nicely describe where your mesh is positioned. When it comes to the side of the mesh placement, and you look back in the last 100 years and you ask these two guys, Jean Rives and René Stoppa, two French surgeons, and they didn't work together, but both of them, they did great job in terms of like trying to find out what is the perfect mesh position, and they defined it for the groin hernia repair. We all know the Stoppa procedure. Jean Rives has focused a little bit more on the abdominal wall repair, but both of them were convinced that the retromuscular or preperitoneal mesh position is the best, and they were right. I mean, there's some retrospective studies here, like IPOM, which is intraperitoneal mesh versus preperitoneal mesh position, which shows that the postoperative complication rate is less when you do a preperitoneal small bowel resection, where less frequent, risk of surgical site infections is lower, and fistula rate is lower. But always keep in mind, it's a retrospective study, so that has always some limitations. But there is a quite recent meta-analysis, including 21 studies, and they compared like inlay, which is very rarely performed basically, but comparing sublay and underlay. Underlay is the IPOM procedure here, and they're ranked in terms of like the risk for surgical site infection and recurrence. And they basically could show that, that a sublay repair is really #1 in terms of the best results for surgical site infection and recurrence. And the underlay, which is the laparoscopic IPOM, is not as good as the sublay repair. So that is the data we have. How about the adhesions? As you know, whenever we talk about laparoscopic IPOM, there is, especially quite recently, an increasing discussion in terms of what is the mesh going to do in the next years in the abdominal cavity. And there are only a few studies which try to answer this question, comparing laparoscopic IPOM with preperitoneal mesh position and omental interposition. 30 patients here, 14-month follow-up. They did an ultrasound examination, and they could basically see 65% of the patients didn't show any adhesions. Although I really have to say, the data they present here are really of limited evidence, because it's a low number of patients. And I doubt that you can really see adhesions with the ultrasound or not. And also in terms of like, when you look back, when you have patients which you operate and they had previous hernia surgeries laparoscopically, then I think that's a more reliable study. And they found that at least 83% of the patients presented with adhesions during the relaparotomy. And this is something which is totally parallel to my clinical experience. We quite often have these adhesions, but the reality is that adhesions are mostly very mild. I can personally remember a few cases where it was very difficult to bring down the bowel from the arterial mesh. Next question, open or minimal invasive ventral hernia repair? Looking back to your initial polls, so a lot of you guys are doing rather the open repair, if I understand or interpret the results a little bit better. So as you know, before we decide what we do, it's important to understand the patient's abdominal wall concept. Do they really need a functional abdominal wall, or is it like the guy on the right-hand side who prefers to sit in his pub and drink his beer, or is it this highly sporty activity patient on the left-hand side? This is something you have to keep in mind also for your surgical approach. But when it comes to the data, comparing laparoscopic ventral hernia repair and open ventral hernia repair, you see that in terms of length of stay or recurrence is no real difference between both of the groups, but in terms of the wound mobility, of course, and this is something which can be extrapolated from all other surgical fields, the minimally invasive approach is the best. That's true, and there is no other reality. Also, there's data from the International Hernia Mesh Registry. 10 years, they collected patients, almost 2,000 of them, and 58% of them were operated in an open fashion. And here you can clearly see that the open ventral hernia repair had a little bit more infections, 3.1% versus 0.3%, but the seroma rate was a little bit higher in the laparoscopic ventral hernia repair group. But again, this is like a little bit an ongoing discussion. Is the seroma really a complication, and how much is the patient disturbed by that? Also, they investigated quality of life parameters, which are significantly better than for the laparoscopic IPOM procedure, especially the longer they wait. After 1 year and 2 years, much better for the laparoscopic IPOM. They also did an analysis in terms of risk for infection and risk for seroma. As you can see on the left-hand side, when you have larger defects and lower BMIs of the patients, then the risk, especially in the open repair for having an infection, is significantly increasing. And in terms of the seroma, you can see here, the lower or the skinnier the patients are and the larger the defect is, the laparoscopic repair has an increasing risk of developing a seroma. But this is something I think we all experience in our daily practice. Answering the question, what is really better now with another statistical approach? This is one of the really good studies from the Hernia Med Registry, where they have just propensity score matching analysis there. So they had laparoscopic IPOM compared to open subtly repairs, and they could construct about 4,000 pairs of patients, which are very, very similar in terms of the risk factor constellation. And you can see here that we have significantly less complications intraoperatively using the open approach, because this is explained by the fact that you do not enter the abdominal cavity necessarily. But in terms of post-operative complications and reoperation rate, the laparoscopic IPOM was significantly better. And then is the question, is there a standard of minimal invasive ventral hernia repair? And the answer is yes, because there are guidelines. There is data from the Hernia Med Registry and also updated guidelines from the International Hernia Society collaboration. And the answer is yes, it's still the laparoscopic IPOM. The laparoscopic IPOM is the standard, the gold standard in ventral hernia repair. That's the fact, because this is where we have the most data, and in terms of most outcomes, especially after surgery, the lap IPOM is still better than the standard open approach. When we say, okay, we go on with the minimal invasive ventral hernia repair, then there's the question of bridging or closing the defect. And the majority of you, if I remember that correctly, is trying to close the defect, and I can only congratulate you for that. I mean, there's different techniques of fascial closure during the hernia surgery. You can either use a suture or transfascial sutures or corporal suture, it doesn't matter. So there are different techniques. One of the techniques should be familiar to you. And why is that such an important topic? Because you have to keep in mind that the linea alba is behaving like a tendon. It's like a central tendon of your ventral abdominal wall. And what happens if you divide a tendon? You can easily see, for example, if you have an injury of the Achilles tendon, if you don't do anything, you will develop an atrophy of the muscles and which are connected to the tendon. And this is something which you can see if you have patients with hernias. Then sometimes the muscles, especially the transverse abdominal wall muscles, they are like weak and elongated and dysfunctional. And this is what happens when the tendon is not working properly. And there's some physics too. If you have, for example, a hernia defect of 7 centimeters here, like this is something which has been investigated by a sports medicine doctor, and you do have a cuff pressure of like 100 millimeters HD, you have like 50 Newton meters of pulling forces, which means this is probably the same like you're pulling with a force of 5 kilograms and trying to pull out the mesh from the abdominal wall. So I think you may not think about, oh, do I had a patient with that size of a hernia and did I bridge it? Yes, no, but this is something you have to consider, that the pulling forces are increasingly higher the larger the defect is, and whenever you do a bridging repair. So keep that in mind. It's just a matter of time when the mesh will very likely just be ripped off the abdominal wall because of the forces they are pulling out the mesh when you cough or when you strain or when you press, whatever you do. And there's some data, some clinical data for that. In terms of like recurrence, there was no difference. But when you do have fascial closure, you have less pain and shorter length of stay. This was a meta-analysis of 16 studies, including 3,600 patients. In terms of xeroma formation and in terms of wound complications, you see that the fascial closure has favorable results. So this is, I think, something you should try to achieve. There's a new study here, a little bit more recent, from 2014, again, systematic review comparing bridging versus closure. And there you clearly see like that bridging is associated with higher rates of recurrence and xeroma, okay? Although the other meta-analysis didn't show that, but the data and the study included in that review were of higher quality. So I think recurrence is something which is increasingly a risk when you just bridge the defect. And this is why the updated guidelines in 2019 just recommended that reconstruction of the linea alba should be performed during laparoscopic IPOM repair because it improves the functionality of the abdominal wall, it decreases the rate of wound complications, it causes less pain, it is a stronger repair, and it reduces the recurrence rate compared with the classical IPOM without closing the defect. One of the rather important questions, and sometimes a point where you have the discussions during the surgery, is like how much overlap is really necessary. And there have been some good studies where they had just 213 consecutive laparoscopic IPOM repairs with bridging, we have to say. And usually they said, and this is how I was trained, like one of my early teachers told me, you should always try to reach 5 centimeters of mesh overlap, and that's gonna be fine. And if you have a look at the left table here, then you see the mesh defect ratio, which is the MD ratio, and what happens if you have an overlap of less than 5 centimeters or an overlap of more than 5 centimeters. And you can see that if you do not have enough overlap, then the risk of recurrence, especially when the mesh is very small, is almost 100%. And only if you have a mesh defect ratio of like over 12 and the overlap is over 5 centimeters, then you have a very, very low, almost insignificant risk of having a recurrence. So you see that overlap alone is not important. More important is the mesh defect ratio. And when you have a look at the right table, then you see Whenever the mesh defect ratio is more than 12, then your risk of having a recurrence is significantly lower. So, and that's summarized that mesh overlap and mesh defect ratio are important to prevent the recurrence. So just talking about the magic 5 centimeters is not enough. You have to keep in mind how big is the hernia defect, and then keep in mind that you have to have a mesh which is 12-fold larger in terms of the surface. And what that means is that, this is another story, mesh contraction lateralization. This is another point, very important. If you do not close a defect and you use the tackers, especially at the contralateral side, there's always a tendency towards pulling the pushing the mesh away from you and then decentralize the mesh so that the mesh defect or the hernia defect is not in the center of the mesh. And this has been investigated by these colleagues here, showing that the change of the mesh area and the vertical and horizontal size is really changing during the procedure itself. So really be attentive of where is the center of the mesh and where's the center of the hernia, and try to avoid some lateral shifting or craniocaudal shifting of the mesh. So coming back to this overlap discussion, I just give you some practical examples. If you have a 5 centimeter hernia, umbilical hernia, and you need a 20 centimeter mesh to achieve a mesh defect ratio which is bigger than 12. And I try to draw a figure here on the left-hand side, what that means. This is really like, it's quite a big mesh if you really want to be safe. But if the hernia is increased to 7 centimeters, then you would certainly need a 25 centimeter mesh to stay above the 12, the magic 12 in the mesh defect ratio. So the mesh, and that's the message, can't be big enough. So always go for the bigger mesh whenever possible. Okay, and this is then how the recommendations have been developed just last year. It's grade C recommendation because the data which are available are not level 1 data, but the mesh area to defect area should be at least 16:1. They say here, I think if you stick with the 12, it's safe. In other words, the radius of the mesh use should be at least 4 times the radius of the defect. And the use of the old 5 centimeter rule only exclusively should be abandoned, because that's not fixing the problem, especially in larger hernias. And one of the last things I would like to highlight is these new extraperitoneal techniques you may have heard about. And there's only, I would say, I would like to focus on the ETAP, especially ETAP repair, MELOS or EMELOS repair, and a little bit I would like to get in touch with the robot repair. But when you look at these techniques, they look quite, when you look at the dissection of the tissue, it looks very similar. It's a little bit like the Baldwin brothers. There are basically 4 of them. They look very similar, but when you get closer, they are still a little bit different. So one of them became good actors, others not. And some of them had good performances, others not. So let's get a little bit more into detail. And if we think about the new extraperitoneal techniques, it's all about understanding the concept of the 3 spaces of the ventral abdominal wall. And once you have understand that, then you realize that all these new minimally invasive extraperitoneal techniques basically do the same. So you do have the retrorectus space, which is behind the rectus muscle. In between the 2 retrorectus spaces, you have the preperitoneal space. This is the space behind the linea alba. And then you have the lateral preperitoneal space, which is behind the transversalis fascia, behind the transversus muscles of the abdomen. These are the 3 cavities or 3 spaces where you move during the extraperitoneal operations. When you have a checkup how you start an ETAP technique, most of the surgeons enter either on the left or the right hand side the retrorectus muscular space, and then they cross over through the preperitoneal space behind the linea alba, and then they enter again the retrorectus space on the other side. Then you can have a minimally invasive retromuscular repair. If you still have to extend the dissection, you can also do a TAR procedure, transversus abdominis release procedure, endoscopically, and enter the preperitoneal space behind the transversalis fascia. So this is what the ETAP procedure does. You can also do it laparoscopically or robotically, and you can pop the cameras wherever you want and have a good visibility from above or from below. It doesn't matter. Or you can look from the side when you have a robot. That's very easily possible. You have a nice triangulation. When it comes to the Milos technique, Milos is the abbreviation for mini-less open surgery. They usually start at the center of the hernia or the umbilicus and enter first the preperitoneal space behind the linea alba, and then they enter the left and the right retrorectus space. But again, in the end, they are at the same level where the ETAP procedure is. And the picture you get is always this. You are looking at the ceiling and you see both rectus muscles dissecting down the posterior fascia of the rectus muscle. And you see the nice white line, which is the linea alba, which is the preperitoneal space. And this is the area where they usually move during these new techniques. And when it comes to the ETAP technique, there's Jorge Dice. He's the inventor. In 2012, he has published this technique for groin hernia repair, but it has been extended by Igor Belyansky from the United States, also using this technique for a retromuscular repair of ventral hernias with good results. But again, there's not much data out there. We need longer follow-ups, we need bigger studies, and it's only a bunch of centers who's doing this type of procedure in a highly professional level. And of course, there's some data from Romania here, from Victor Radu. But when you just have a quick look at the data, then you see that surgery time, for example, is like for an incisional hernia or for ventral hernia, so there have been umbilical or epigastric hernias too, is like 2.5 hours at least. Operation time was even longer. And when you need a TAR, like a component separation, you're almost extending like 4 or sometimes 5 hours. And this is, to my personal idea, is like a little bit too long and not really acceptable. And this Victor is one of the experienced surgeons. He knows what he's doing, and he still takes so much time. The Milos technique, which is the technique I prefer when it comes to these new minimal invasive techniques, beside the laparoscopic IPOM, has been invented by Wolfgang Reinpold from Hamburg, from Germany. And as I showed you, he enters the preperitoneal space first, and then connects to the right and to the left into the retrorectus space. And then you have a nice working area. And you can see here on the right-hand side, then you can close the hernia defect with a suture, and then bring in the mesh and have a nice repair. And Wolfgang has the advantage that his technique has been investigated in quite good studies, comparing here in the hernia mid registry 600 patients with almost 6,000 patients which have been operated laparoscopically with an IPOM, or 6,000 patients with an open sublay. And when you look at the data comparing Milos with the laparoscopic IPOM, you see that the Milos technique has several advantages. And this is especially true when it comes to the open repair, open sublay repair, but also, again, this is my critic for this study, this is only data coming from Wolfgang's clinic for the Milos repair. I don't know what the data is when other surgeons start with this technique, so we have to wait for these results. But this is quite promising, and it will certainly be a challenge for the laparoscopic IPOM repair. So in the end, what is my personal tailored approach for the hernias, for the ventral hernias, especially for umbilical and epigastric hernia first? Usually when it's below 1 centimeters, I just do a direct closure. When it's 1 to 7 centimeters, I try to keep or stay minimal invasively. I either do an IPOM plus, or which means I close the defect and do an IPOM, or I do a Milos repair. And very rarely ETAP, I'm rather one of the Milos guys. And when it comes to very big hernias, like more than 8 centimeters, we do as a pre-operative preparation botulinum toxin infiltrations in the abdominal wall. This is not topic of this talk, but this is what we try to do. And then we do a straight open subtly repair. And if the Botox has not helped that much, we may do a TAR or an endoscopic component separation to achieve the primary fascial closure. When it comes to incisional hernias, it's a little bit more simple. If we are below 8 centimeters, we go for the minimal invasive repair, and we do either the Milos repair or the IPOM plus repair. And if the defect is larger than 8 centimeters, we again usually take our patients to the radiologist who is infiltrating Botox 4 weeks prior to surgery, and then we do a straight open subtly repair. Sometimes in velos, depends a little bit, plus minus TAR. This is my approach. And this is basically the end of my talk. I hope it was not too long for you. There are lots of informations, and I'm sure that there are going to be a few questions. I would not like to finish before I advertise the Swiss Hernia Days. As you already know, and I mentioned that we had to cancel the Swiss Hernia Days, the 4th Swiss Hernia Days this year because of the Corona pandemic. So we have another try next year, which will be at the 9th and the 10th of September 2021. We will have a cadaver workshop, and you're going to find all the information on our homepage, swissherniadays.com, and I'm happy to answer questions now. Thank you again for Medtronic to inviting me to give this talk. And I hope I could bring a little bit of light into this sometimes complex discussion of minimal invasive hernia repair. Thank you very much. And I'm happy to take the questions now.
So
I was
thank you,
asked,
sir.
okay.
Do you have two polls, more 2 polls?
Yes, I forget about that. Yeah, right. So let's do the polls first. Okay, which long-term complication following ventral hernia repair seems to be most worrisome to you? Is it chronic pain? Is it recurrence? Is it seroma? Or is it adhesions? Go ahead. Recurrence. Interesting. Okay, good. Next question. There was the last one. For which new extraperitoneal technique do you see the biggest potential in your working area? And I'm especially asking this because some of the countries, they do not have the resources we have here in Switzerland, and some countries you are happy if you can do laparoscopic repair, very basic one. So I'm interested, do you see any role for this technique, yes or no, in your country? Please go ahead. ITA. Interesting. Okay. Very good. I'm not on both. Yeah. Interesting. Okay. Good. So I will, if I'm right, I will read one of the questions which have been raised. Is that right? And try to answer them?
Yes. So we'll go for Q&A session. We have almost 10 questions if we open the box here.
Yeah. I've seen that. Okay, first question is the IPOM technique enough, and how can I improve the results? I'm not so sure whether I understand this question correctly. Improving the results is something which begins with the planning of the procedure. So what I usually recommend is to do always do any type of imaging modality before you set the indication for surgery. For example, we use, if the hernia is smaller, we use an ultrasound. If the hernia is a little bit bigger, we go straight for a CT scan, because that helps to consent the patient, and that helps to plan the surgery, because you should always measure the hernia defect in a CT scan. And when you remember my decision tree, it is a difference whether the hernia is 6 centimeters or 9, or it is a difference whether it's 2 centimeters or 5, because that changes the whole setting for the surgery. So if you do a laparoscopic IPOM, and you should try to close the fascial defect, but the hernia is 7 or 8 centimeters, then you have to have a backup plan, what you're gonna do if you're not able to close the defect, because that's maybe a little bit difficult. So then you have to get ready to really put in either a big mesh, a really big mesh, the biggest you can have, or you have to change the technique and switch over to open ventral repair, or do Botox application first and things like that. So I think this is when you consider these things and consent the patient in the correct manner and use appropriate size of a mesh, then you will have very, very few complications and good results in terms of recurrence, at least. I hope I could answer this question then. Next question is, what is the standard definition of a complex abdominal wall hernia? There is no standard definition for that. I did show you the publication, which tries to answer all the, or to highlight all the factors which are defining a complexity. As I mentioned, if you just operate on a recurrent ventral hernia, this is a complex abdominal wall hernia, because by definition, recurrence or previous abdominal wall or abdominal operations increase the complexity of the hernia. I agree that there's no grading like grade 1, 2, 3, or 4, but you do have risk factors which are defined in this publication, and I invite you to read this paper. It's very interesting, and they at least differentiate between minor, moderate, and severe risk factors, which are increasing the risk for having complications, because that is what a complexity is causing. If a thing is very complex, a hernia is complex, it is associated with an increased risk of intra and post-operative complications. But a real standard definition is not available, I'm sorry. Yeah, next question is, how can we avoid a xeroma formation, and when it occurs, and what are the therapeutic options? Xeroma formation is, to my personal opinion, not really a surgical complication, because a xeroma formation is a physiological reaction of the tissue. It can be very annoying. It can be worrisome for the patients, especially, but I think, and I hope I could highlight this fact, you can reduce the risk for xeroma formation, especially when you do an IPOM repair, by closing the defect. I think this is the primary measure you have to take. If you can close the defect, do it, because that is significantly reducing the risk of having a xeroma. When you're technically well trained, what you can try while you close the defect is to get pieces of the hernia sac into your needle and your thread. And then you can try also to shrink and to fold the hernia sac, which is additionally reducing the risk for having a xeroma formation. When it occurs, it depends. I would say if you do not close the hernia defect and you do an IPOM repair, you will have a xeroma formation in 100% of the patients, because it's a physiological reaction. The question is only if the patient is disturbed by that, or if he really realizes that there's a xeroma. If you have very adipose, obese patients, they may not even realize that there is a xeroma formation. But when you have the skinny patients, you may remember the table and the picture I showed you. Especially the larger the defect is and the lower the BMI is, the more is the risk, or the higher is the risk of having a xeroma formation. And if you have a very skinny patients, a patient who is potentially smoking, I think you have a picture in mind how these patients look like, and you do an IPOM repair without closing a defect, I mean, they will see and feel the xeroma, and they may feel disturbed by that. If you have it, I always advocate my patients and consent them that we have to wait. I would, at the first 2 to 3 months, not do anything. Only if I have the impression that there is an infection going on, or that the pain is not bearable. But before I would do any intervention, I would do a CT scan first to have an idea of what's going on and how big is the seroma really, or is there recurrence I may have overseen, whatever. And there are some people who then after a while perform like punctions, like aspiration of the seroma formation. But the problem is that the seroma formation will redevelop even if you have drained all the fluid out. And you always, with every intervention, you always have the risk of having an infection of the seroma formation. And once the seroma is infected, your mesh is infected too. And this is then, again, a very complicated situation. So summarizing this question, whenever you have a seroma, what are you doing? I'm doing nothing unless the patient is really disturbed by that, or it's painful, or I have the impression that something is going on there. I wait, I consent the patient. It can take weeks or even months. In most patients, in my practice, my personal practice, after 6 months, all the seromas are gone. So really, really be cautious there, and don't overdo things. Like, give him some time and give the body time to get rid of the fluid and to absorb it. Okay. One question is, when we do IPOM, how can we close a larger ventral hernia defect in a thin abdominal wall in a female patient with a history of previous multiple pregnancies? I don't know whether you refer to a hernia or a diastasis recti. I think this is something which needs to be defined first. Maybe this person can address on that by standing or answering its own question here. So I will skip this question. Good question now. Do we measure the overlap before or after the closure of the defect? Good question. Before. That's the important thing, because when you close the defect, your hernia defect is 0. So you do it before, but this is a very frequent question. So the important thing for the overlap is the hernia defect. And you can measure that either in a CT scan before surgery or during surgery. It's up to you. But you should calculate the defect size, the mesh size, basically before surgery, because usually you are then surprised that you need a larger mesh. And sometimes if you need very large meshes, they are not on the stock, not on the rack. And so you're struggling to find a large mesh, and then you may make compromises and put in smaller meshes, and that's not good for the patient. So I always would measure that before and calculate beforehand the surgery, which size of mesh do you really have to use. Okay. Next question, best type of mesh and fixation technique. Best type of mesh is, the reality is we have more than 240 meshes on the market. I think no company can really claim that their mesh is the best. There have been a few meshes which performed very, very bad from another company. You may know about them, where they had to take the mesh from the market, and there are a lot of trials going on now where the patients try to sue the company. It's luckily not Medtronic, but there are, I think most meshes perform equally. It's just a matter or a question of what you are used to do and what you think is the handling is the best. So I will not comment on that. It's a very, very personal decision. In terms of fixation technique, if it comes to laparoscopic IPOM, you do have to use penetrating fixation techniques. So I prefer to use absorbable tags. If the hernia defect is very, very large, I sometimes may use transfacial fixation sutures, stay sutures, but I think if you use the double crown tacker technique, you're on the safe side. The most important thing is you try to avoid mesh dislocation and mesh shifting during the tacker application. What is the recurrence rate? I think it highly depends, as you have learned now. It depends on which type of technique you use, how big is the hernia, and do you close the defect, yes or no? So I can't give you a concrete number here, but you just have to look at the data and then you know what the reality is. For laparoscopic IPOM, we also have a recurrence rate of about 20% after 5 years, or potentially even more. And the reason for that is that most defects are still not closed routinely, and that the mesh, for convenience reasons during the surgery, has been chosen too small. And I think this is something you have to keep in mind. For example, if you have a 5 centimeter hernia defect, nice umbilical hernia, and you use a mesh which is 15 centimeters of diameter using the 5 centimeter rule, that is very likely ending up in a recurrence within the next couple of years. So I think when you have a look at the data at the moment, they may look worse than they will be in 5 years, because we are learning every year. And you guys take home, this is one of the major messages, that the 5 centimeter rule is not enough. You have to keep in mind the mesh defect ratio. Next question is about the BTA Botox A method. Whether I can just quickly comment on that. We do that, as I mentioned, as soon as the defect is larger than 8 centimeters. And the whole aim of the Botox application is to avoid component separation and to make the whole procedure easier. When you have a very, very good effect of the Botox, you can operate on large hernias very easily. You can do a direct closure even for bigger defects, and you do a nice sublayer repair or IPOM, whatever you like. How we do it is we do the preoperative CT scan first to measure the defect diameter. Then we send them to the radiologist who is doing the BTA application. And the BTA is, there are different protocols for that. And there's, again, I have to highlight, this is not standard, and it's the Botox, there's let's say no label use, it's an off-label use, because the companies, they are not interested in getting a license for their products to be used for hernia surgery, because this, for them, financially, it's not very interesting. So we will potentially never have a real protocol which comes from the company. But what we have been doing in working groups is that we came up with ideas and suggestions how to do it. And there's a big working group in South America, in Mexico, and there's a big working group in Australia. And usually they use like between 100 or 200 units of BTA for each site. It should be infiltrated 3 to 4 weeks before surgery, because this is when the agent develops the biggest relaxation of the muscles after 4 weeks. And it should be injected into the 3 oblique muscles lateral to the rectus muscle sheath. So the transversus, the obliquus externus and internus muscle. And then there are different opinions on how many units and on how many locations, and so there's no consensus about it, but it still works quite well. And 4 weeks after that infiltration, we perform the surgery, and after 3 months, the temporary muscle relaxation is finished. So then the Botox stops working and the muscle strengths come back. Let me just go through a few questions. Yeah. What do you think about open ventral hernia repair with IPOM technique for large incisional hernia? I think there are a few questions going in this direction. I think this is a hybrid approach. And sometimes if you do not, if you think the hernia is quite big and the sublayer repair, the retromuscular repair would not be sufficient, it's a good idea. So I know a lot of surgeons in Germany who do that very frequently. But I think the whole advantage of doing an IPOM is that you can do it minimally invasive. If I have to open up the abdominal cavity, like with a laparotomy for repairing the hernia, then I would potentially switch over to a sublayer repairs to put the mesh behind the rectus muscle and not into the abdominal cavity. only if we have a recurrence after retromuscular repair and this anatomical plane is like gone, then it may be a good repair or a good possibility to do that. But I'm not so sure whether you can really put the mesh in the perfect position, because you do not have this nice sealing effect where you just look from below up to the abdominal wall and you can put the mesh there and you can fix it with the tackers and you have a nice visual control of your mesh position. This is always something which is missing in the open approach, because you can only see the mesh from outside, from above, and you do not have much control where the mesh is really going and is it folding, yes or no. So I think this is really just a backup plan when you have no other solution. It would never be the first step approach for me in my surgical field. I would never do that as a first line method. I hope this answered the questions quite well. I'm asked about the BMI limit for ventral hernia repair. That's a very good question, because this is something which is increasingly important, especially in the first world countries where obesity is a massive problem. A lot of surgeons who are really faced with lots of obese ventral hernia patients, they are offering bariatric surgery first, because we know obesity is increasing the risk for having complications. You should, whenever possible, try to operate minimal invasively in obese patients, for example, using laparoscopic IPOM repair. But of course, there is a limit, and the cutoff level in most studies for where the complications are really rocketing into the sky is 40. So whenever you're reaching 40, you should be focusing on bringing down the BMI first before you do the ventral hernia repair. So what we usually do is we do a bariatric procedure first and close the defect, just closing the defect as good as possible, when it's possible at all, during the bariatric procedure. Then you have the weight loss procedure. And then if the hernia is symptomatic or comes back or a patient is still disturbed, we go for the permanent repair. That's what we do. But I think below 40, I'm not so concerned, but it's all like an individual setup and things. And doing a laparoscopic repair can be very, very difficult when you have like 10 or 15 centimeters of fat, which you have to penetrate with your instruments and things. And then you have these strange angles and the fulcrum effect, and you need a lot of force on your instruments to move them inside the abdominal cavity. So that's going to be difficult sometimes. Okay. One interesting question is, there's someone saying that he's regularly doing ETAP repairs. He has done 70 cases so far, very good, including ETAP with a TAR, and he still finds it difficult. Do I think that the Milos technique is easier to start in the hernia itself? I can only say yes. This is the reason why I'm not doing the ETAP repair, or only very, very rarely, because the advantage of the Milos repair is that you can, at the beginning, skip the endoscopic instruments. So most hernias you can repair with a nice retractor, with potentially we need an additional light source. We don't need that, but I think it's easier for that. And you can do it with two people. So Philip and I, we do it together. It's quickly done. And only for larger defects, we can switch from the normal Milos repair to the endoscopic Milos repair, which then where you need then a gas insufflator, a screen, but not more basically. So I find the ETAP procedure, to be honest, difficult, but it's always a question of experience. If I see Victor Rado doing it, or Jorge Dice, or Igor Beliansky, it looks super easy. But the same is true if you look Wolfgang seeing his Milos repair. So it's all potentially a little bit of what you're used to. But what I would strongly recommend is, before you start a new technique, go to someone who's doing it frequently. Try to get a place in a workshop or visit someone who's doing frequently, really that you get an experience from first-hand experience in the operation room for new technique. And I would not recommend just seeing it on videos and then trying it on patients. There's so many things you can do wrong, even with techniques which look simple at the beginning, and then you can really increase your learning curve when you visit someone or visit a workshop. I can only recommend that. Next questions. Okay, just let me go through someone and okay. One question interesting, which addresses to the pain issue. One of the major problems this person is writing post-IPOM is severe pain due to the tackers. That's true. I faced it many cases after surgery, and the patients need longer hospital admissions. And how can you deal with that? What I try to do is, first of all, consent the patients, because the problem is they think, oh, I'm going to have a minimal invasive repair, and then they think pain will be minimal as well. But especially when I know that I am operating IPOM, a laparoscopic IPOM, I specifically consent the patients for the pain problem. And then you should perform a good analgesic therapy and treatment in the first couple of days. Really strongly do that. And what helps, in my opinion, is to apply an abdominal binder, an elastic one, because this is decreasing the shaking of the abdominal wall when people move, when they stand up, when they need to cough. They have a little bit more stability, and the movement in the tissue is a little bit less. So this is certainly helping to decrease the level of pain. But I agree, penetrating devices, they cause pain, but this is unfortunately the only way how you really can fix the mesh when you apply that in the laparoscopic IPOM technique. But I think when you manage the patient expectations before the surgery, that can help too. That's a very, very important thing. Okay, I will screen through more questions. Yeah. Good question here. If the patient comes after ventral hernia repair and he presents with a recurrence, what will be the approach? This is something where we do not have guidelines, and this is where it comes down to personal experience and logical thinking. I think what we have to do is to extrapolate the things we know from inguinal hernia repair. So when we had an open Liechtenstein repair, then the recurrence should be managed laparoscopically and the other way around. And so I think this is true for the ventral hernia repair too. So when we had a laparoscopic IPOM and the patient comes back with recurrence, the redo operation should not be IPOM. It should be either Milos, ETAP, or a straight open retromuscular repair, because you should not make an operation more complicated than it needs to be. So always try to find the anatomical planes which are not used yet. So the retromuscular plane, for example, which has not been touched by the IPOM mesh, and the other way around. If you have open sublet repair, the patient comes back with recurrence, then you do an IPOM. And last week I operated on a patient who came back with a recurrence following IPOM repair, and the recurrence was just at the edge of the IPOM mesh, and I just did a Milos repair there, just minimal invasive. It was perfectly possible, no problem. So, and only if all planes have been used, like you have the second recurrence or third recurrence, then you should do where you think you feel technically the safest and the best educated, then you should go for it. Sometimes it's easy to do a re-IPOM. When you have no adhesions and no bowel stuck at the mesh, you can easily do a re-IPOM, although we don't know how well the mesh is integrating if you tacker the mesh onto the previously implanted mesh. Well, we don't have data for that, but that's a backup plan. The results of operating a re-recurrence or third recurrence are anyway very bad. Okay, there's one question for Botox. Do you think that Botox can save the patient from component separation? That's exactly the point. So we still waiting for results from a study which is running, where they usually did Botox in very large hernias, and the component separation, these are preliminary results from Austria, was only necessary in 20% of the patients, which means 80% of the patients, which very likely would have to have component separation, didn't need that. And that's the whole thing. The Botox can downstage the complexity of the procedure. So you very likely will not have necessary component separation, because that is increasing the risk for complications by 3 or 4 times. So you avoid that. And what is also true is that the level of pain is much lower. So this is what we experience too. And the reason or the explanation is that Botox itself has an analgesic component, which is not quite understood so far. And the other thing is, when you think about how the pain develops, you have a midline incision, you have a suture there. And when you're waking up and you're moving your body and you do everything, then your oblique muscles, they're pulling, they're working. And so they're putting tension on the suture, and that's causing pain. But if your oblique muscles are flaccid because of the Botox, they cannot pull. So I think the tension on the suture is less after surgery, and this is also helping to decrease the level of pain. That's true. Let me screen through more questions. In case, interesting question, which is referring to small bites technique. In case of defects more than 8 centimeters, elective open sublay repair, how do you close the fascia? Is it with small bites with 2O or traditional 1O PDS suture? So we usually do small bites technique because the data for that is quite convincing. There have been some contrary data published last year, but I think for me, it makes totally sense. The only reason when it really doesn't work is because you haven't performed the small bites technique correctly. But if you do it really correctly, I always would go for small bites. And we use a 2O Monomax, which is a long-term absorbable thread, which absorbs after 18 months. PDS is a possibility, but I'm always afraid a little bit like PDS is absorbing a little too quickly, I think. Remodulation of the abdominal wall is finished after 4 to 6 weeks. So the suture material should at least last till that time. But when you think about that the strength of absorbable suture material is decreasing earlier than it absorbs totally, which is logical, then PDS may be a good option, but you are safer if you're using long-term absorbable threads. But you have to ask your providers if they have, or companies if industry partners, if they have that in their shelf. Yeah. Would you repair a parallel rectus diastasis with the umbilical or ventral hernia? That's a good question. Usually the question is set up in the other way around. If you have a rectus diastasis and you have a ventral hernia or umbilical hernia, do you just close the hernia? It depends on the patient and depends on the complaints. Rectus diastasis is presenting in 2 types of patients. The first patients is the women following twin pregnancies or multiple pregnancies, which is suffering from instability of the abdominal wall and back pain. And the other patient is the obese elderly man, which rarely recognizes that he has a diastasis recti. So I almost never operate on diastasis recti on men, but I usually operate this type of disease in women. And when it comes to that repair, you should, of course, if you put the rectus muscles together, you close the umbilical hernia, that's true. But if you decide not to reconstruct the diastasis recti and only focus on the hernia, then you have to keep the one thing in your mind, that it's important that to understand that even in smaller hernias, like 1.5 centimeters or 1 centimeters, if you just do a suture repair on the basis of a diastasis recti, you have a 5 to 7-fold risk of having a recurrence, because the basis of this recurrence is just elongated dysfunctional linea alba, which is not really giving the same strength like a normal healthy abdominal wall. So whenever you decide to operate on a hernia, even on smaller hernias, on a diastasis recti, you should try to reinforce your sutures with a mesh, even for smaller hernias, because otherwise you're very, very likely to run into recurrence after 2 or 3 years. So this is the reason why I usually recommend to fix the diastasis recti too. And when you go a little bit more into detail, when you see the patients, ask them specific question, they will tell you that they have instability, they have pain, functional problems of the trunk of the abdominal wall, and then it's a good indication to perform or operate on both things.
Sir Hoffman, that's we have
yes.
almost 10 minutes remaining.
Okay.
For the last 20 questions, we have still remaining 20 questions, so we have only 10 minutes. Okay. Just a quick remark.
Are you happy if I go through a few more questions?
Yes, it's still we have 10 minutes.
Okay, okay. Good question here is like, how about using drains to prevent xeroma formation, especially after laparoscopic IPOM? Drain is not preventing xeroma, because xeroma formation is a physiological reaction. And if you really want to prevent it, you have to keep the drain in for at least 10 days, I think. Because usually the xeroma formation develops not straight after surgery, but within the first couple of days or week until it reaches its maximum. And you cannot put drains in for such a long time. That's not sufficient, and that is increasing the risk of having an infection, etc. So, like for example, the colleagues in the United States, they almost never use drains because they're so afraid of causing infection of the mesh, blah blah blah, and to get sued. So we almost never do that. We only do that in larger repairs, but this is more for like evacuating bleeding and hematoma, and to have like an indication if the bleeding is going on retromuscular or something. But for excuse me, for preventing xeroma formation, a drain will not help. It will only keep the patient in the hospital, and it's only a risk factor for infection. What may be a little more helpful is to apply an abdominal binder, because then you passively reduce the dead space in front of your mesh. Okay. I will get some more question. Yeah. How do you treat postoperative prolonged ileus after laparoscopic hernia repair? So I really have to say I only occasionally had patients like that, but there's not much you can do. You just have to wait. Of course, you have to make sure that when there's really an ileus and patient starts vomiting, you have to use a nasogastric tube, etc. But for paralysis of the small bowel, there's not much you can do despite chewing bubble gum, walking around, using elements of the enhanced recovery protocol. For example, you can give a little bit of magnesium sachets. You can, try to drink coffee. There are a lot of things you can try, but you have to keep in mind that once you really have developed a paralytic ileus, you have to wait 2, 3, or 4 days until it resolves itself. Of course, there have been a few cases reported where they had like early adhesions to tackers or to the mesh. And if the ileus is not improving, I would go for a CT scan and see whether I can find a kinking of a small bowel loop or like a closed loop or something like that. But I never had such a case, but it's possible. Okay. But then, of course, if you have a kinking, a mechanical problem, then you have to do a re-laparoscopy. And always try to resolve this problem. If you really have to get back into the abdominal cavity, try to resolve the problem laparoscopically. But I think it's only very, very rarely necessary. Very good question. Do you close or remove the sac, or do you leave that a hernia sac? If I do a laparoscopic IPOM, if I'm doing a defect closure, which I always do, I try to get the sac into my suture. So I will pull the sac down and guide it through my needle so that the hernia sac gets some sort of like shrunk together, and that is decreasing the dead space and decreasing then the risk for having a seroma formation. Sometimes when the sac is like defragmented or tiered into several parts, I would invest some time to remove it, to really dissect it out of the hernia cavity and then close the defect. But usually it's not necessary. You just pull it down. You can help yourself with the other hand and pull down and press down the hernia, and then you can easily reach it with your needle, and then you can just integrate the sac into your suture. This is how I deal with that. Okay. Oh, that's a good question here. So that's focusing a little bit on the biologic meshes. What is your opinion in huge defects which are even not suitable for component separation? Do you prefer special meshes like biological meshes? So first of all, if you cannot close the defect, biological meshes are contraindicated because they will absorb within a few weeks, and then you will have a hernia recurrence immediately. So you should only use biological meshes or bioabsorbable meshes when you have a good layer which is closed where the mesh can do its work. If you have a case where you did everything like component separation, Botox administration, or even pre-operative pneumoperitoneum, and you cannot close, then you should at least have a heavyweight mesh, a strong mesh, where you suture the edges of the hernia defect, which you cannot really put together. You suture that on the mesh too. So you have like a bridging area, which you have to keep as small as possible. And then you can, if necessary, and if you're convinced that it does something, then you can put your biological mesh on that permanent mesh to help to remodulate the abdominal wall a little bit quicker. So there are a few surgeons in Spain, like Miguel Garcia Orena, who's doing it very frequently in that manner if you cannot really close the defect. But usually a biological mesh alone or a bioabsorbable mesh alone for hernia surgery and a ventral hernia defect without closing the defect is not working. That's ending up in disaster after a few weeks, okay? And also the biological meshes, just to give a small comment on that, there's no indication anymore for that in ventral hernia repair. There have been studies by the FDA in the United States that they basically do not do what they promise. So basically, biological meshes should be really kept for very special cases, but for ventral hernia repair, there is a new focus on the so-called bioabsorbable meshes, where the matrix is not coming from or derived from animals. It's more derived from synthetic fibers, synthetic production. There are some products from other companies, which are not important now, but just that you have this in mind. But again, the database and the level of evidence is very low, very, very low still. So we need to wait until we have results back from bigger studies who are really investigating the effect of these meshes and the efficiency in ventral hernias. Yeah, someone is asking what I think about registries. I'm personally a big believer in registries for two reasons. First of all, it helps me to monitor my performance. So you can only improve your performance when you measure what you're doing. Then you can basically manage your problems. You can see where you're especially good at or where you're not so good at. And you help to give a database for research. But there's sometimes, of course, like, let's say, criticisms which coming up that, of course, this is not really reflecting the reality, because only like 5% in Germany, for example, 5% of all patients who undergo hernia surgery are registered in registries, and the other 95% are nowhere in terms of data savings. So, but I think at the moment is the best we have to gain data as quick as possible and to understand what we're doing and to improve our daily business. Okay, I think we are finished by time now, Bahar. Is that right? Can you hear me?
It's fine. We can go through those questions quickly and pick like the most impactful question we have. We can leave only 2-3 minutes more.
Okay. Okay. Yeah. Good question here. What can I do for chronic pain after laparoscopic IPOM due to tackers? Chronic pain is defined pain not or being ineffectively treated for 3 months with all conservative measures. I think what you should do first is doing a CT scan where you can mark the point where the patient suffers from the pain. In most cases, it's a trigger point where it's painful, and then you can correlate that to the CT picture. And when you do not see, let's say, any kinking of a loop or changing of the soft tissue there, like which would suggest that some infection or some fibroma or neuroma is going on, then I would start treating this trigger point first with local anesthetics, long-term local anesthetics, and then increase the treatment frequency and accelerate or escalate the treatment further. You can have percutaneous nerve ablation, for example. And if this is all not working nicely, you have to surgically evaluate and elaborate this pain trigger point. You just have to open up there and see what you find and try to resect everything. That may help. But there's no guideline for that. It's just like, as I mentioned, a stepwise approach. And try to get in good radiologists who can help you with the CT scans. Try to seek some help from pain specialists, etc. Don't do it on your own. Always try to develop a team. You're working together. It's much better for the patient. Probably a last question. Just let me screen through some things here. Yeah. Just quick, probably a last one. Yeah. Can you give us a formula again for choosing the size of the mesh? I think the presentation is recorded, and you will get a link where you can download it, or a link to the platform where it's provided. Again, as I mentioned, the old 5 centimeter rule is not valid anymore. You should try to achieve a 12:1 mesh defect ratio. And then it is just like simple math. If you have a defect of like 5 centimeter, you have like 5 by 5 centimeter, or don't know, it's like 25 square centimeters, and then you need the 12-fold size of the mesh, which means it's like 275 square centimeters mesh size, and you have to measure that. It's easy to calculate. You may just need help with a calculator in the operation room. But this is the reason why I'm suggesting to do it before surgery, because you should know the defect size before you start the operation, and then you know the size of the mesh before the operation too. Okay.
I think this brings us to the end of our webinar. Thank you, sir, for this very interesting presentation and webinar. And I hope you enjoyed also, and I hope all our attendees enjoy the experience. And on behalf of Medtronic, I would like to thank you again, and we will be connected always and check your availability, next availability, to have another successful webinar like that of today. Yeah. So thank you again, many thanks. And please, can you allow me to announce for the upcoming webinar also as well?
Sure, no problem. Thank you very much.
Yes, so thank you, sir. Thank you, everyone. I just need to highlight for the upcoming webinar, and hope it will be interested for the audience. So I will share now. And it will be also by Dr. Marius, is from Greece, and he will cover the groin hernia or TEP technique. So hopefully it will bring a value for you. And share the link also in the chat box so you can register immediately to join us at the end of this month. So this is from my side. Again, Professor Henry Hoffman, thank you a lot. I couldn't express my thankful on Medtronic also for this nice and very interesting presentation. I received a lot of feedback from the audience. All are very, very positive. And of course, I will share with you after the call, after the webinar. Thank you again, sir, and have a great
Thank you very much. Bye-bye, everyone. It was a pleasure.
Bye-bye. It was a pleasure. Thank you.
Thank you.
All.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye-bye.